It may be disgustingly warm here in the UK at the moment, but I want you to imagine yourself fast-forwarded 6 months' time, and 2 babies arrive in your department on the same cold January night. Both of them are under 6 months of age, both are working hard, and both are getting admitted under paediatrics. We swab them, and one swabs positive for RSV, and the other doesn't. And the single biggest difference between them isn't anything about the baby. It's now whether their mother had a vaccine. And that's not a hunch. It's the finding of a new study out of 37 UK hospitals, the first real look at what our maternal RSV programme is actually delivering, now that it's stopped being new and started being routine. So, in this fortnight's episode, we're looking at the effectiveness of the maternal RSV vaccine. We're examining new data on whether asthma scores can tell you who needs admitting. And in What's Caught My Eye, we've got retinal examinations in suspected abuse, why we scan the head injuries the rule tells us not to, and how often a child with a CNS infection gets sent home first. It's a proper PEM week. I'm Ian Lewins, and welcome to 2 Paeds in a Pod. Welcome to 2 Paeds in a Pod, the paediatric medical education podcast about thinking clearly when it comes to child health. Each week, we take a paper, a clinical dilemma, or a tricky topic and work through what it actually means for your practice. So, whether you're in emergency care, general paediatrics, or you see children as part of a wider healthcare role, this is a place to step back, challenge assumptions, and sharpen your thinking. Welcome to the show. Before I start, a quick acknowledgement. Back in episode 85, we covered a French cohort which compared nirsevimab given at birth against the maternal vaccine, so a head-to-head between 2 products. This week, we're looking at a different question and a different paper. That one asked which is better. This one asked whether ours is working. If you've been listening a while, you're allowed to feel we've been here recently. Stay with me, because the answer this time is our own data from our own hospitals. Here's where we are. In late summer 2024, the UK started offering the bivalent RSV perfusion F vaccine to every pregnant person from 28 weeks. After an initial catch-up push, the programme settled into year-round delivery. Then, in late summer of 2025, nirsevimab replaced palivizumab for the babies at highest risk. So, we now have a 2-part prevention strategy. Vaccinate the mother and give the monoclonal to the small group who need it directly. The trials told us the vaccine worked. Trials always do. That's rather the point of running them. What nobody knew was what happens when you take a product out of a trial protocol and hand it to a national programme with real uptake, real timing, real people forgetting appointments, and real clinicians having conversations at 28 weeks that don't always land. That gap between efficacy and effectiveness is where health policy goes to die. This study is about that gap. This is BronchStop. 37 hospital sites across the UK, a prospective test-negative case control design. And a detail I want to flag before anything else, a group of parents shaped the protocol. And that's not decoration, it's how this sort of work should be done. The method is straightforward once you see it. Take every infant 6 months or younger admitted with an acute lower respiratory tract infection, swab them for RSV. The ones who test positive are your cases. The ones who test negative are your controls. Then compare how many mothers in each group had the vaccine. The elegance is that everybody in the study got ill enough to need admitting, so you strip out most of the difference between families who bring their baby in and families who don't. Between the 2nd of September 2025 and the 31st of January 2026, they screened 1,356 infants and 694 went into the primary analysis. 429 RSV positive, 265 RSV negative, and the median age of just over 2 months in the positive group. Now the number that does the work. Among the RSV positive babies, 38% of mothers had been vaccinated before delivery. Among the RSV negative babies, 66% have. Sit with that gap for a second because everything that follows comes out of it. Adjusted for site, calendar month, gestational age, socioeconomic status, age at admission, and breastfeeding, the vaccine effectiveness against hospital admission with RSV was 61% out to 6 months of age. Confidence interval 38 to 75. And in the first 3 months, the babies who scare us most, the ones who apnea rather than wheeze, it was 76%, with an interval from 54 to 87. The whole programme, taken together, came out at a 61% through to 6 months. The caveats are real, and you should think about them. This is observational. Test negative designs handle a lot of confounding, but they don't handle all of it. And mothers who accept a vaccine differ from mothers who decline in ways no adjustments fully capture. It's one season, and the primary analysis deliberately excluded babies born before 28 weeks and those who had nirsevimab. So this is the effectiveness of the maternal vaccine in the population it was designed for, not a verdict on the babies at the edges. Now, for the so what. Well, 2 things, and the second one is the one that I want you to carry with. First, the vaccine works, and it works best exactly where we need it to. 76% protection in the first 3 months of life is a genuinely large effect against the illness that fills our beds every winter. When a parent asks you whether it was worth it, you now have a British number rather than a trial from somewhere else. Second, and read that control group again, 66% of mothers of babies who did not have RSV had been vaccinated. That's roughly a third of women in this cohort who didn't take it up. This paper is a story about a vaccine that works and a programme that isn't reaching everyone. Those are 2 very different problems, and only one of them's been solved. So, the conversation at 28 weeks matters. If you work anywhere near antenatal care, or if you have that conversation opportunistically when a mother brings an older child to you, this is now a number you can offer. Our second story this week is about something quieter, and something that's been creeping into our departments without much scrutiny. We're all familiar with the classic wheezy child. You see them, you give burst therapy, you wait, you look again, and you decide. That decision, home or admit, is one of the most frequent judgments in paediatric emergency medicine, and it's always been a judgment. Experience, gestalt, the look of the child, how the parents seem, what time it is, how many beds you've got. And for a couple of decades now, there's been a push to replace some of that with a number, whether it be PRAM or the pulmonary index score or the paediatric asthma severity score. There are dozens, and the appeal is obvious. Objectivity, consistency, something a junior can use at 3 a.m, something you can audit. Several of these have quietly appeared in UK departmental pathways as disposition tools. And the question nobody's properly asked is whether they're any good at the thing we're actually using them for. So, what study are we talking about? Well, this is CASPER from the PREDICT network. 4 Australian emergency departments, a prospective observational study. Children aged 2 to 18 who got at least 1 dose of bronchodilator. Trained research nurses, not the treating clinician, took the observations before and after that first treatment And from those observations, they calculated 10 different asthma scores on every child. 1,238 patients, 64% were boys, and the median age was 3. Just over 41% met the admission criteria. They set the bar in advance. To be useful, a score needed an area under the ROC curve of at least 0.8 for telling admitted from discharged. And the results? Not one score got there, not one. The best 4, the Modified Pulmonary Index score, the Pulmonary Index score, the Paediatric Asthma score, and the Siriraj score, managed between 0.7 and 0.73. Everything else was worse. And on the second test, whether any score could strike a decent balance between sensitivity and specificity, none reached a Uden index of 50%. Here's the nuance, and it matters. Every single one of the 10 scores did show that a 1-point rise meant higher odds of admission, and highly significantly so. The scores are not measuring noise, they're measuring severity, and severity is real. The caveats? Well, it's Australian, and their threshold for admissions aren't ours. It's observational. And there's an obvious circularity risk. If clinicians saw the observations, the score is partly predicting a decision it helped make. And look again at that median age of 3. A large slice of this cohort is preschool wheeze wearing an asthma label, which is a different disease with a different natural history. So, what's the bottom line? Well, these scores measure how sick the child is. They do not tell you what to do about it. That distinction sounds slightly academic until you write it into a pathway. A score that discriminates at 0.72 is a reasonable way to track a child over the next hour, hand over between shifts, or trigger a senior review. It's not a threshold you should be discharging on, and if your department has one embedded as a disposition rule, this paper is a reason to go and look at it. The decision is still yours. That's not a failure of the scores, it's what the evidence says they're for. I'd also check this against the current joint BTS, NICE and SIGN asthma guidance before you act on it locally, because my read is that national guidance has never endorsed these scores as disposition tools in the first place, and I'd verify that wording rather than take my word for it. Now then, let's move on to the 3 papers that have also caught my eye this week. First up, the retinal examination you probably don't need. This is a multi-centre retrospective study of 2,591 American children under 2 undergoing a child protection evaluation, all of whom had neuroimaging that showed no intracranial injury. And it asked how often we look at the retina and what we find when we do. And the headline from this paper was that only 10.5% had retinal examination at all. And of those 272 children, 4 had retinal hemorrhages. That's 1.5%. Every one of the 4 also had a plausible alternative explanation. So why does this matter? Well, if the head imaging is clear, the yield of dilating the eyes is close to nothing, and the authors argue the examination can safely be deferred, which spares a distressed infant, a distressed family, and an ophthalmology colleague. The caveat here is the exception the authors carve out is real. Suspected strangulation or signs of direct ocular trauma still warrant a look, and this is US practice, so let's be careful to map it onto your own safeguarding pathway rather than around it. Paper 2 is why we scan the head injuries the rule says not to. This study is a prospective multi-centre study that did something unusual. It surveyed 421 clinicians about their experience and their tolerance of risk, then linked each one to the 8,957 PCAN negative children they'd actually enrolled. The headline finding was that 7.3% of children at very low risk were scanned anyway, The things that predicted it weren't features of the child, they were the clinician. More years of practice, seeing fewer children in your day job, and measurably, a personal dislike of uncertain outcomes. Why does this matter? Well, this is the most honest paper of this fortnight. The rule works, we know the rule, and we override it for reasons that live in us rather than in the patient. Of course, there are caveats again with this. Self-reported risk tolerance is a soft measure. And again, this is a US cohort where the baseline CT rate runs well above ours. And finally, the third paper, the meningitis that went home. This is a cross-sectional study across 5 US states of 2,686 children admitted with meningitis, encephalitis, or a craniospinal abscess, asking how many had been seen and discharged from an emergency department in the preceding 7 days. 1 in 10, 10.6%, with a median gap of 2 days was found. In children over 90 days, more than 3/4 of those first visits were logged as nothing but flu-like symptoms: fever, headache, vomiting, tiredness. Only 6% had a red flag-like altered mental status or neck pain. And why does this paper matter? Well, 2 things. In bacterial cases, that missed visit carried 2.5 times the adjusted odds of neurological complications, and the risk of missing it was nearly 4 times higher in the lowest paediatric volume departments, which in our system means the DGH, the Urgent Treatment Centre, the place seeing children occasionally rather than constantly. The caveat on this paper is that this is an administrative coding data, so a missed diagnosis here is an inference from a pattern, not a case review. Some of those children were genuinely well 2 days early, but not all of them were. So 3 things I'd take away from today. Number 1, the maternal RSV vaccine cut hospital admissions by 61% to 6 months and 76% to 3 months in 37 UK hospitals, and 1/3 of the mothers in that study still hadn't had the vaccine. Number 2, not 1 of 10 paediatric asthma scores predicts admission well enough to be a disposition rule. Use those scores to track severity and handover. Don't use them to decide where a child goes. And number 3, 1 in 10 children with a CNS infection was seen and sent home in the week before admission, usually looking like a virus, and the risk was highest where children are seen least often. As always, for all the papers, all references and DOIs are in the show notes on our website. If this episode was useful, please share it with a colleague. Thanks for joining me, and I'll see you again in a fortnight. Thanks for spending your time with us on 2 Paeds in a Pod. If this episode sharpened your thinking, make sure you're following or subscribed wherever you listen. Share it with your team, use it in your next teaching session, and let's keep the conversation going. If you value this kind of learning, please leave a rating or review. It genuinely helps more clinicians find the show. We'll see you next time.